COVID juga, dan juga kadang di bangsal. Kalau ditanya pengalaman selama pandemi ini, terutama kalau ngobrolin pandemi pas masa Delta ya, itu kadang kalau saya ditanya gimana pengalamannya itu masih merinding sekali, dan juga kadang di bangsal. Di semua tempat di rumah sakit ini tuh semuanya chaos. Saya dan teman-teman saya pengalaman selama pandemi ini, terutama kalau ngobrolin chaos. Wow, ini sesuatu gimana pengalamannya itu masih merinding sekali, dan juga kadang di bangsal. Di semua tempat di rumah sakit ini tuh dan kita harus belajar adaptasi dengan cepat. Tugas kita tetap menolong pasien-pasien supaya mereka survive atau menyelamatkan yang masih bisa diselamatkan. Seperti itu. Kalau di IGD suasana itu udah kayak ICU, bukan IGD lagi. Di poliklinik yang harusnya pasien bisa jalan, udah kayak IGD. Bangsal biasa itu udah kayak semuanya ICU. Dan pasien itu antri di depan rumah sakit itu sudah biasa. Ada bahkan suatu saat waktu saya jaga, pasien antri naik mobil, dibawa mobil atau motor atau mobil dengan bak terbuka, kemudian tolong kami, tolong kami. Dengan gejala yang pasti itu COVID. Tapi IGD kami sudah full. Kami bisa apa? Kami sarankan ya ke rumah sakit lain. Ada beberapa yang mencari rumah sakit, tapi tidak dapat. Kembali ke sini, yang awalnya saya periksa, oh ini masih bisa ditolong. Oke, ke rumah sakit lain. Ke rumah sakit ini lagi sudah tidak bernyawa. Hal-hal seperti itu.
Sak gendho-gendhone deknen yang namanya kemanusiaan tetap kita tolong. Mbok kuwi sing ngomong membaresah dekne sesuk lara, tetap ditulung. Kan kadang-kadang ana to sing posisi wong Covid ngene iki. Ora kabeh wong iki gelem nyerak. Sedangkan wong kuwi butuh perhatian. Nek dekne ra dopeni kuwatengene, ya kelakon mutar. Saiki 3 dina ora mangan ning jero kamar terus. Anake ora nilai. Alhamdulillah kuwatengene pangerten. Waktu itu ambulan merebak itu memang kita tidak punya. Kita itu pinjem dari ambulan Lazismu punya Muhammadiyah waktu itu. Kalau ada apa mesti Lazismu. Tapi kan Lazismu kan tidak cuma melayani di gereja saja. Lazismu itu di semua Tegalrejo. Kadang-kadang ada panggilan di mana. Kan mereka kan juga capek, keterbatasan personil juga. Kita jaga ke puskesmas ya tadi mau. Dateng-dateng ngene lek kangenan loh. Sedangkan ya nek puskesmas ibaratnya Bu iki butuh bantuan ini iki. Kono gelem telepon. Masih retine ngono. Ha kene sing nangani wong iki terus nek pengalaman pribadi sing paling paling berkesan ini mungkin nggon pemakaman kuwi wih banget. Itu bulan Juni kae. Jikuki mayat ning Sarjito wan banyake minta ampun itu. Yang mayat pada belum dikapan, belum diurus, kan banyak banget. Itu selama berapa hampir 1 bulan. Kene deterus aku. Psikisku sing ra kuat. Saiki gawean wis opah banget. Makam wis dina kok sampai ping 2 ping 3 SOP ini kan harusnya 1 kali. 1 hari pemakaman. Nek ngomong ke sini, wah, jan bener-bener meh. Aja nganti meneh lah.
Setelah pandemi yang Delta dan di pertengahan Delta, saya tergabung dengan tim pengabdian masyarakat dari Fakultas Kedokteran untuk melakukan pengabdian masyarakat di area Krica. Nah, di situ saya merefleksikan diri bahwa kita semua ternyata berjuang di masa pandemi ini. Tidak hanya saya dengan teman-teman saya di rumah sakit, tapi semua orang juga merasakan perjuangan itu. Mereka juga sedih ya bareng-bareng, berjuang ya bareng-bareng. Bagaimana mereka bisa survive di pandemi ini dengan supporting system mereka.
Siap. Jos. Pripun Pak RT? Oh siap Pak RT. Jos.
Karena saya melihat bagaimana orang-orang relawan-relawan di daerah Krica itu yang bahkan bisa jadi tidak dibayar, tapi dengan ikhlasnya membantu sesama. Itu sangat mulia sekali. Dan mereka juga berjasa banyak dalam menolong orang-orang. Untuk mungkin membantu membawanya ke rumah sakit. Kalau tidak di rumah sakit, bagaimana tetap survive tapi di rumah, dengan logistik yang ada, dengan vitamin yang ada, dengan pantauan kesehatan yang ada. Mereka hebat. Dengan membentuk sistemnya sendiri, itu jadi semakin menguatkan saya bahwa kerjasama dari semua orang itu perlu. Di saat, kalau bisa dilihat rumah sakit ini sebagai bagian dari institusi pemerintah, tapi mereka adalah institusi sosial yang membangun diri mereka sendiri supaya kuat. Itu sesuatu yang besar. Ketika pemerintah tidak bisa mengcover semuanya dan mereka dengan mandirinya hadir dan melakukannya, itu sesuatu yang besar dan saya bangga dengan mereka. Keikhlasan, rasa gotong royong itu sangat penting.
Dan bekerja, kita juga tanpa biaya, kita semua apapun gratis, ya toh Mbak. Kami sudah 24 jam untuk pengantaran orang yang mau ke rumah sakit, apapun dia mau swab, kalau minta bantuan mau ke rumah sakit, kami mengantar dengan mobil.
Dan bisa jadi rasa keikhlasan, gotong royong itu yang membuat kita survive bersama dari pandemi ini.
Padmawati MA, the Director of CBMH UGM, the Honorable Speaker Professor Dick Willems, MD PhD, the Honorable Faculty members, distinguished guests, ladies and gentlemen. We honored to welcome you to the lecture of visiting professor with the topic Digital Technology in Healthcare Deliveries, presented by special speaker, Professor Dick Willems, MD PhD from Amsterdam University Medical Center. Professor Dick Willems has been collaborating with Universitas Gajah Mada since many years ago. And since last week, he's quite busy to present a lot of topics in many forums such as Rabuan Forum and Symposium. I'm Anissa and I'm your host today. Before presentation, let me introduce and read the curriculum vitae of Professor Dick Willems. Professor Dick Willems is a professor of medical ethics at Amsterdam University Medical Center since 2003. The research interests and supervision of PhD students include ethical aspects of genetics, ethics of big data research in medicine, palliative care, end-of-life issues, and home care or self-management technology. He is a principal investigator and a researcher on numerous projects with both national and European funding, and is an ethics advisor on EU-funded research projects. He is a co-leader of the personalized medicine program within Amsterdam Public Health and leading the ethical and societal work packages within two large EU-funded studies in cardiology, Escape_Net and Profit. Professor Dick Willems, without further ado, please, time is yours. You will present it about digital technology in healthcare deliveries. Time is
Okay,
yours.
thank you very much. Terima kasih. Selamat sore. Is it sore? Yeah.
Yeah.
No, yeah. Okay. I never know exactly what it's what, but so I'll continue in English. That's a lot safer. And more important. So this is the so I'm really happy to be able to present some of the developments in digital technology and also some of the ethical issues related to the technology, digital technology as we have it. Ah, is it still on? So maybe I should hit it from time to time then. Okay, because otherwise it falls asleep and I have to. So I think it's an important subject where I think all over the world digital technology is growing, and it's also applied more and more in healthcare ethics, in healthcare deliveries. So and it raises sometimes specific ethical questions. So I'd like to present to you. I can't speak about all digital technology, of course. I'll just take some examples that I'm personally a bit more involved in doing ethics research in. But I would also ask you to maybe if you have a question or a remark or an experience that you want to share, just do it and just tell me that there's some. Wave your hand. I'm always very happy to get into the discussion because otherwise I have to speak maybe a bit too long too sometimes. Okay, can I have the next, please? So this is one of the, I think, the landmark WHO publications, which is about what they call the global strategy on digital health. So, and I think that the concept of digital health is really a concept to keep in mind. It's we're not speaking about digital technology, but about digital health. And digital, now it's sometimes difficult to find a precise definition. It's in fact the use of digital technology in all kinds of areas of health and healthcare. But the WHO has adopted this global strategy. Can I have the next, please? And WHO Europe has also issued a report which is in line with the global report, of course, and they enumerate what is it about 10 important areas of digital health. So this is all part of digital health. It's telemedicine and telecare. So care through, let's say, a video connection with a patient or through a video connection with another doctor. That's telemedicine and telecare. Electronic health records, and especially also interchangeability of electronic health records, is one of the areas of digital health, so that various doctors can look into the same electronic health record of patients. Mobile health apps, so the kind of things that you probably have on your telephone, and they're increasingly used for monitoring patients with chronic disease, and sometimes also for prevention, so for preventing the disease. So, I mean, the most clear example of a preventive mobile health app is the steps counter that many of you probably have on your phones, where you can count the steps so that you know if you've walked enough on a day or have been sitting around too much. So that's the mobile health apps. Then one other form of digital health is the public health portals that provide access to individual health records and to the context that individuals have with the health system. And they use that for public health campaigns. and also for monitoring, let's say, both non-infectious and infectious disease. Is a form of digital health that has been very prominent during the COVID pandemic, where often the expansion of the rate with which the pandemic grew was visible in the type of context that individuals had with their health professionals. So usually at health centers like Pusmas or other health centers, and that kind of digital health records is increasingly used to follow and to predict where new outbreaks will be. So because you can usually see that to some extent happening in the context that people have with for instance, their GPs or with nurses. So that's an important point, one that I will not be speaking a lot about, but I think it's important to realize that digital technologies have been very important in the tracing of the COVID pandemic, I think all over the world. So it's really an important. Integrated care delivery is something that you can do using digital health. For instance, if you have a meeting about a patient and you want to have everybody who's involved with that patient in the meeting, for instance, the GP, but also the medical specialist from the hospital and maybe other caregivers, then digital health solutions may be used for that as well. Then we have clinical decision-making support in primary care, not only in primary care, I think it's almost everywhere. That clinical decision-making support. I will be addressing one example that I'm currently investigating about that kind of decision-making support. Then there's a whole area of digital health in the use of robots in healthcare. It's as you probably know, in fact, robots may be used in two contexts. They may be used to, for instance, medical operations, where you have operation robots, where they can do a surgery, where they can do robotic surgery. But I think even a more important use of robotics is in the care for older people, at least in the West. We get more and more older people who live alone in the community and who don't have a lot of people visiting them. And increasingly, robots are used to replace human beings there. So if they don't have any children around, or they may not have any children at all, then sometimes robots are used to replace and to replace that contact. And you can have a lot of ethical concerns maybe about that use of digital health. Then there's another application of digital health in the area of personalized medicine. So that's a form of medicine in which treatments and diagnostics get more and more personal, individualized. And as I will show later on, if you want individualized healthcare, you often need a lot of data about a person. And digital technologies can be useful for that. Then you have nanotechnologies. They're also part of it, but I'm not going to speak about it because I'm not an expert in nanotechnologies. I know almost nothing about it. Is artificial intelligence. And I'd really like to discuss some of the issues about artificial intelligence with you because it's really coming up, I think. So the main issues that I will be speaking about are the red ones. So I'll focus on these four health. And maybe what I'll do is after each example, I'll ask you if there's any questions, because otherwise you will have forgot about telecare and when we're at the end. So I'll split it up in parts of, let's say, 20 minutes, and then you have, and there may also be questions at the end, but we'll do that a bit this. Okay, can I have the next one, please? This is a quote from the same WHO Global Strategy report, and it says something about what can be expected from digital health. So it has the potential to enhance health outcomes. So maybe a digital, like a computer or artificial intelligence, will be better able to make a diagnosis in an individual patient. We'll return to that when I speak about artificial intelligence. Database treatment decisions, so they may improve treatment decisions. I'll have an example of that I found myself quite, because it goes quite far. Digital therapeutics, which to me is the same as treatment decisions. It will also change clinical trials a lot. I'm not going to say too much about that here, but the change from the standard clinical trial to much more data-based science is an important change, and it will change our thinking about science itself, but also about the ethics of science. Right, so that's clinical trials. It will change self-management. So people will increasingly use digital technology for self-management as well. So we'll speak about that when I speak about what they call mHealth, so mobile health. Person-centered care will be, well, that's in fact the personalized medicine issue. And it will create more evidence-based knowledge, skills, and competence to support care. So that's the potential. Can I have the next one? I have a few quotes from this report because I think they're important to realize what can be accepted. So it should be an integral part of very poor countries in very poor circumstances. They need to develop a policy on digital health because it may be very beneficial for their populations. So it should be an integral part of health priorities, but it should also be ethical. That's what WHO says. So here's really a task for ethicists and for people studying ethics to take care that digital health is done in an ethical way. It should be safe, of course. So it should be, that may have two meanings. So the data should be safe. That's the first meaning, but also the patients should be safe. So there should be no risk for patients, additional risk when you use health should be accessible to really everybody. Should be available in a just way. It should be just something for the rich. Yes. Oh, I changed the mic. Okay. Oh. Which this one? Is this one better then? It's better, maybe. Was it so bad? It's a bit far away. So now I'm tied to a string now here. So I can't walk that way now. But well, anyway. That's okay, that's no problem. So and I think there's a few important other concepts that they're talking about at WHO, but it should be developed with transparency. And that's sometimes difficult because, especially if you look at artificial intelligence, for instance, it's very difficult because to be transparent about artificial intelligence, because in fact, at some point, nobody knows anymore how it works. So it's really difficult to be transparent. It should be accessible, as I already said, scalable, so it should be usable on a high enough for, in fact, also for everybody. Interoperability is an important issue here. In research with data interoperability is the real big issue, I think, mostly. Privacy, security, and confidentiality should also be taken care of. So this is what a little bit about the ethics, I think, about digital health, what WHO says about the ethical issues related to digital health. Can I have the next, please? This, I think, is an important aim that we shouldn't forget, because we tend to look at it maybe from an individual viewpoint, but I think one of the main promises of digital health is in public health. So it's in societal issues. So it has the promise to prevent, detect, and respond to epidemics and pandemics. And so it should also enable infrastructure for countries to promote health and well-being on the basis of these pandemics and epidemics. So as I already said to you, it can be used to detect early detection of where new epidemics or pandemics are arising. So I think that's what I wanted to say about this WHO report on possibilities, the potential of e-health, of digital health. So I don't know, is there any question about that here or in the online? I didn't say anything to the online people. Welcome that you're there. It's really nice that you participate in this. And if you have, I see there are quite a few things in the chat, but they may be on about the microphone all the time or not. They're mainly on the microphone. But if it would be an interesting question there, I would really like to hear it. I hope the microphone, is it working well now? I hope it is. So no more chats about the microphone, I hope, are necessary. Good. All right. So can I get to the next, please? So this is in fact the outline of what I will be talking about, maybe the next 3/4 of an hour or so. So I'll start with an area that I've done some research in, and that's telecare, not so much telemedicine, but I'll mainly be speaking about telecare. And then I'll say something about mobile health apps, and then about personalized medicine, and I'll end finally with artificial intelligence as an issue. Okay, so next, please. This is, here you see an example of telecare in Britain, I think. I think this picture has been taken in England, where you see an elderly lady who's possibly in need of frequent monitoring or frequent consultations. I imagine that she has one or more chronic diseases that need to be monitored. So she speaks to her physician. You can see the physician on the computer screen. And so they'll do this maybe every month or every 2-3 months. They will have a conversation, and the physician will ask how things are going, and she can do that from her home. So I'll say a bit more about the promises. Can I have the next one, please? So this is the definition of telecare. Telecare is already a bit old-fashioned, but it's still working. So it means you speak about telecare, or care at a distance, it's sometimes called, care at a distance. You speak about that when the care receiver, so the patient, and the caregivers are not in the same room. As soon as that's the case, then it's telecare. And in fact, so when a doctor and a patient speak over the telephone to each other, that's already telecare, because they're somewhere else. They're not in the same room. But we're quite, at least in the West, the telephone is used a lot between doctors and patients. So we're used to that for a long time. Then email may be another form of doing telecare, or WhatsApp, or whatever system you have, or Instagram. Sometimes some doctors communicate with their patients through email or other forms of social media. So that's another one. And you obviously have internet and video consultation. And you saw an example of video consultation just now. And now video consultation has become much more important, at least in the Netherlands, during the COVID pandemic, when we wanted as little as possible that people travel to healthcare institutions, especially for people who were living at home and needed monitoring and were older and vulnerable. Telecare seemed to be a very good solution. So there were a lot of people communicating with their doctors and nurses through iPads. And it's even the case that iPads were made available for family, for instance. If a patient was admitted to hospital with COVID and nobody could come near that patient, the family also couldn't visit them. So then iPads or laptops were used for communication. Can I have the next one, please? That telecare may be the effect. So let's say that's the promises of telecare. I'd say it promises, it has a potential. One of them, of course, is efficiency. It takes people a lot less time if they don't have to, especially here in Yogyakarta. If you have to go through the traffic jam here, it takes you an enormous amount of time. But Amsterdam is not much better, but well, anyway. So it's efficiency, and especially also efficiency for home care services, who don't have to go to visit the patient all the time, so they can see a lot more patients through cameras and video consultation than through, let's say, standard visits. And it also makes it more easy for patients to get in touch with their caregivers. So we did interviews with patients who were taken care of through video consultations, also to look at the ethical issues, because we were expecting that many patients would have ethical problems with video care. But that was not very often the case. Most of them said, it's so much more easy to see my doctor now or to see my nurse now through the monitoring. So it makes them also increasingly independent and more autonomous. I think that you can say that there's also more profit. Welcome, Romo. Nice to see you again. So it's also increasingly that people get more, that there's profit in this business, but that's, well. And one of the things that we now have in the Netherlands, I don't know if you have it here, but after the pandemic, there has been a lot of personnel shortage in care, in caregivers. So people increasingly went to do other things like vaccinations, or they did all kinds of other things, and they got into other jobs. And possibly this could be a solution to personnel shortage, especially also because the efficiency is higher. And it may make it finally cheaper as well. So people expect it to become cheaper if you don't have to travel, and it takes less time. Now, some of the worries, and that's, I think, where ethics come in. There may be some worries about care at a distance through video consulting. Can I have the next one, please? Oh, this is a quote from one of the patients we interviewed, and who was very happy with this possibility. The gentleman said, "I've been living in the place where it was since 1965, and this is one of the most important things he's experienced. Nursing homes and hospitals have been closed down," he says, "so that we need to travel a lot." So we see that patients often have to travel longer distances to go to a hospital or an outpatient clinic because of the closing down of hospitals, as he says. So thanks to this, he says, we don't have to travel as much. I think that's an ethical advantage. It increases accessibility, because otherwise he would have maybe stayed home and not be seeing his nurses. So I think that's a real ethical advantage, a positive thing. Now to the worries. So I always like to start with the positive things and not immediately start with the worries about everything. So maybe the next, please. Can I have the next? Yeah, this is a bit in between. This is an image of, let's say, what we see as a modern house. And I think the nicest things, I hope that people online will be able to see that, are these things that are built into houses. Don't know if you can see it, but you see that there's an internet connection from the door here. So one of the things that you can do with this form of, and here the chair also has an internet connection. And maybe the bed, you don't see the bed, but usually the bed also has an internet connection. So what you can have is if someone is living alone, an older person, and I know that here in Indonesia, that's less common than in Holland, I think. I think that in Holland, more older people live alone. And for them, it may be very good if someone can check at a distance if they left the house or if they are still sitting in their chair or if they leave their bed. For instance, in the middle of the night, some older people may get confused. Like because of old age, sometimes confusion comes in. And then this type of things is always, oh, what happens now? Where is it? Little technical problem. Okay. So that's, you can use telecare and this type of technology also to see what they do, to monitor. Now I think there's obviously an ethical issue there. I don't know if any one of you wants to say, if you realize that that someone Christmas is behind his screen and he can detect whether a person is still in his bed or in her bed, or is still in the chair, or has maybe left the house. What would the ethical issue be there? I mean, who would want to say what? Does anyone see an ethical issue there? Of course, it's privacy, I think. So that may really be a problem of privacy. It's maybe better if I don't have this on. Do you allow me to? Will I be, the police won't come along? No. All right. Okay. I'll probably take it off. I think it's better for the sound, isn't it? Yeah. So there's obviously an issue of privacy, even if people have agreed with all this. This is called domotics. I don't know if you have it here, but if you don't have it, it will not take long before it comes, because these things are spreading so quickly. This type of indicators in the house, it's called also the Internet of Things, because it's in fact the things that take over, that get in touch with each other. So there's a camera somewhere far away here, and it is contacted by the chair or by, and sometimes the bath also. So if you want to know if a person still goes to the bath to clean himself, then you could put a sensor in the house that gives the data to a center, like a nursing center, and they will be able to see if the person is still doing that or not. But as you say, I think there's a clear issue of privacy there, especially if sometimes some people want to do things secretly. So I think I have an example. Can you do the next one, please? Oh no, I'll tell you the example. It may be somewhere in my PowerPoint, but then I don't know. There was an example of an older man who had a little bit of dementia. It was not terrible, and he was living with his wife. And as some people with dementia, this person, he had a tendency to go out at night because he mixed up day and night. And that's what they often do. So day became night and the other way around. So what happened was that he left the house, and then sometimes in the middle of the night, he didn't know where he was. So he got lost somewhere in a part of town. And his wife then had to follow him in. She knew a little bit where he was going to pick him up again. So finally, the solution was that he had his telephone with a GPS, and it tracked where he was. So when he was walking around, it was tracking where he was. And then if he threatened to go out of the area or to go to a place that he didn't know, then a healthcare service would come after him, let's say, to pick him up. And that could happen at 2 or 3 in the night if he was walking around. So, and he agreed with this. Because he knew that sometimes it was a bit difficult for his wife, so he agreed. Oh yes, because the alternative would have been to lock all the locks so that he couldn't go out, and she didn't like that idea too. So she wanted also for him to have his freedom. Now, one of the things that they discovered through the GPS, and then you see the privacy issue, was that he went to the same address every night. And maybe you can imagine what it was. Anyone has an idea what he was doing at that same address all the time? Well, you start laughing, so I think you have an idea. I think you have an idea. Anyone that doesn't understand what he was doing? Timmy, do you know what he was doing? Yeah, he was seeing someone, exactly. So it was all quite nice and friendly, but he had someone to see somewhere else in the town. So they discovered through the GPS where he went. And I think that shows a bit how that can be difficult for privacy if you can see those things. And he didn't want his wife to know. He also said it's nothing serious, it's just someone I like. But we're seeing each other from time to time. It was nothing threatening. And then finally they discovered, and the end was all right. It's a good end story because his wife didn't mind so much, because when he said that it was nothing threatening for her, she was quite okay with it. But then, so that's to show you how such systems can be quite dangerous for privacy and for the quality of life of a person. So there is a few worries, I think, about what we call care at a distance. So can you give maybe this jumps to, maybe you can put, that's a pity. Well, go to the last one. Yes. So the one thing about care at a distance in general, not only GPS tracking as the example had, but care through a computer screen is safety, of course. Because you don't know if what the person tells you is what really is the case. You don't even know if the person has fallen recently or if anything happens to them. You don't know if you have enough contact to be sure that you have a good idea of what the problem of the patient is. Because sometimes they may tell some things, but you may see something different. And that disappears if you only have this. So that's one thing. So safety is one of the worries. It's one, I think, of the ethical issues related to using this form of telecare. So I think that you really can use it occasionally, but not as a complete replacement of physical care. So you also have to see someone. They also have to come, or you have to go there. So that's the first one. It's usually a particularly vulnerable population. So can I have the next, please? Well, we've already been speaking about privacy. It's a form of surveillance that you can have, in especially the kind of things that I showed with the chairs giving signs and things like that. Autonomy, and for some people also dignity is involved. For instance, if you would have cameras, a sort of, what's it called, CCTV camera system in the home, it sometimes happens. Some of the homes, as a part of domotics, have TV cameras to be able to spot the person and see what's happening. For instance, for fall prevention, I don't know if you have that a lot here, but one of the biggest issues in care for elderly is falls. I just this morning read that the number of falls in elderly people in the Netherlands has doubled the last year. And that's falls. I mean, and you can think a fall is a fall, it's not very important. It leads to death sometimes because these people get admitted to hospitals and then they finally may not survive even a quite simple fall because they break their bones easily. So falling in elderly people is a real issue. So maybe a camera might be a good idea because then you can see where people risk to fall. So we sometimes see that there's a table in that is on the wrong place, and so they may stumble into the table, so that you can change things. Well, what I wanted to say is that if you put cameras in, some people also feel that that is contrary to their dignity. It's not only privacy, but also dignity, not to be seen all the time. Even if you're just in your home, you want to have some freedom to do what you want and not be observed by other people. So dignity is really an issue, I think, here. And the next one, please. I think what a lot of physicians and nurses are worried about if you go to more video consulting is what I already said a little bit, is the decline of face-to-face care. So that you rely too much on what happens through video consulting. So the direct conversation disappears. And I think there's always a difference. We all did a lot of Zoom and video during this last pandemic. And I haven't spoken to anybody who said, this is a good form of contact. I would like to keep it this way. Because for most people, if a contact through a camera or a video has less quality than direct face-to-face contacts. And I think that's partly because, thank you. That's partly because it's more difficult to just chat on the video. You're a lot more businesslike on a video. Things go. So I think we have learned through the pandemic that contact through video and video care is always a bit less satisfying than face-to-face contact, unless you talk to someone you dislike. I mean, some people that I'd rather see on a screen than in face-to-face, but that's rare, you know. That's just for, yeah. And another direct conversation disappears, which has effects on the quality of care. So it's an ethical issue also, I think. And also indirect signals. So the things that people don't say, they also disappear. One of the nurses that we interviewed around the use of video care in the COVID pandemic said that I always, when I come into a home, because they did home visits, she did home visits. She said, when I come into a home, I immediately know how well it goes because I smell it. Because if there's a smell of, let's say, rotten food or something like that, then she knows it's not going well. The patient is depressed or is too tired to do the wash up or things like that. So she says, I'm missing smell and I can't look around in the house a bit. So what she had is just the screen and nothing but the screen. So indirect signals, and I think direct signals are very important in care because you see how someone walks. For instance, they only sit before the screen. You don't know even how someone walks. Don't know if you've had that. We were talking about that around lunch. There were some people I've never seen before, only on the screen. And then you don't realize how tall a person is. And you don't realize how they walk, you know. It's maybe not always important, but sometimes it can be important. Next one, please. So this is what I already had. And one of the issues that comes back all the time with this type of technology is the question of accountability and responsibility. I will be saying more about that in the other examples as well. So the question is, who is accountable if it fails? So what if the camera breaks down? Or what if the mobile app that should monitor someone gives the wrong information? Is that the physician who has prescribed the technology? Or is it the tech company? Or is it maybe the artificial intelligence itself which is responsible? We don't know that yet. So who's accountable if it fails? That's really, I think, a recurring issue around all forms of digital health, all forms of digital technology. Right, next one, please. So this was the part about telecare. Does anyone have a question or a remark or an experience? Do you have a lot here in Indonesia already, video care, or not much? Conversations between, let's say, nurses and doctors with patients over the video. Is it happening or is it still? More in private. Clinics do that more than puskesmas and state hospitals. Right. So you have to request it specifically. That's what you say. It's an application that you have to make for it. Yeah. Yeah. Okay. Yeah, I think we saw it really a lot happening during the COVID pandemic. So it was really increasing a lot. You know, there's one issue that I now remember I didn't mention, and that was we did a study. So we did interviews with people, with doctors and patients who had video consultations. And one of the things the doctors, and that was very interesting, I found, is that they had no idea who was in the room apart from the patient. Because there may be all kinds of other people in the room listening with you. So they said it may be very, very threatening to professional secrecy. Because as a doctor, you can't say everything to the family member. Sometimes there's a secret that you have to keep. And if you don't know who's in the room, then that's one of the issues that they mentioned. They didn't know. One of the other issues that they also mentioned that was that some of the doctors worked from their homes. And then they had the same problem because their family members also were in the room while they were doing consultations. So in fact, their family members were seeing patients sometimes. I think that's something that's really, you can't do that, but it happened because it was now this was COVID-19, of course, so it was an emergency thing and it was quickly organized, but it's one of the issues that you have to take into account. If you do care at a distance, you have less knowledge about who else is in the room. Okay. Anyone, any remarks about, because I'm not going to speak about video consultations any longer. Any remarks about this? Okay, from the chat. All right. Let's take the chat. But we're doing that later then. Yeah, I'll be speaking a bit more about artificial intelligence. So I'll come back to that later. Okay. Good. We can go on about mobile health apps. Who doesn't have a smartphone here? Does anybody have, do you all have smartphones? Yes, of course. Well, we all have smartphones, of course. Does anybody has only one smartphone here? Yeah, so I see many people who have many smartphones. Well, some of you have just one smartphone. Okay, that's good. I have one smartphone too. And do you have any health apps on your smartphones that you use? I mean, they sometimes come with the smartphone. But do you use any health apps? Which one do you use? Yeah. It counts. Yeah, sure. Yeah. For COVID tracking. Yes. I know. I have it on my phone as well. It doesn't work for me. No. So I tried everything. I put everything in it. And it has been waiting for confirmation for about a month now. So I'm not sure which high authority is checking my app. It doesn't work. It's very optimistic, but it doesn't work. No, I'll show it. I even had it in my presentation. It's one of the apps. Yeah. But are there any other apps that you use, like Hello Doc? Hello Doc. And what does that do again? What's that? Yeah. with a doctor at the somewhere in the internet. Yeah. So you do that if you have you can do that if you have a complaint, you have a headache or something like that. You do a first consultation with the Hello Doc. All right, nice. Yeah. Oh yeah. Okay, I didn't know that. I don't have it on my phone, so no. Can I have the next one? So this is the kind of things that we all know, of course. I mean, they're down at the left. You see is sort of that's a cardiologic app that has the blood pressure and it has your number of heartbeats. And then, but the other apps, most apps now are about lifestyle. So about weight and about numbers of steps and about how many push-ups you did. You know, did you do a lot of push-ups? I didn't do any. Yeah, walking. Okay. Yeah. Okay. You know, and there's the one that I show there in the upper left corner that's called Check is an app that you can use if you have a lesion on your skin and you're a bit worried about it. So it takes a picture and then it sends it to a database and then it will compare it. That's already artificial intelligence, but so it will compare it to other images and then it will finally give some idea about whether it's something to worry about or not. So whether it's a melanoma or some other dangerous lesion or just something brown that you shouldn't worry about. This is a risky one, I think. This is one of the things that people worry a lot about. Can I have the next one? Oh, yeah, there they are. Yeah. And the other one is, I couldn't find the Dutch one because we don't have the tracking app anymore. It didn't work, so we stopped it. But we do have the vaccination app, but not the tracking app anymore. So this is the kind of apps that we all think of and that we all use because we're forced to use them in a sense, yeah. Please, next one, please. You know, there's quite a number of health apps. I was going to ask you the question, but the number is already there, so I'm not asking the question. But usually people think there's about 2,000 or 3,000 around. But if you look at the internet, the numbers are increasing every year. It's over 100,000 health apps that are offered by all kinds of internet providers and websites. And most of them, as I already said, are lifestyle apps. So they count your steps, they measure your calories. But there are also more and more diagnostic apps, like the one for the skin. But in fact, Hello Doc already is a little bit of diagnostic app because it gives you a first idea about what your complaint may mean. So it's already a little bit of a diagnostic app. And there's also, at least well, they're accessible everywhere, but not in all languages maybe. But there's also more psychological apps, a lot of them. So a lot of them, for instance, if you wonder whether you're depressed or not. It's strange because you usually feel it, I think. But some people may wonder if they have a depression, if they need to go see a psychologist or a doctor. So they may use a screening app for depression. So this is really increasing very fast. And this is called direct-to-consumer e-health. And these are apps that anybody can download from the internet. Paying or not paying, it's anybody can do that. So can I have the next one, please? I think it's important to realize, and we during our palliative care symposium, we already talked a little bit about business and ethics. And I think it's important to realize that we as ethicists don't often talk about business, but there's a lot of business behind health apps. And I think it's important to realize what the business models between health apps are. So I think there are, in fact, 3 business models. You know, do you ever pay for health apps? No. Does any one of you download a pay? No, you all download the free ones. Yeah. Are they free? Do you think they're free? No, they're not free. Why are they not free? Because you don't pay for them, do you? Your credits? How do you mean? Ah. Oh, you pay through the oh yeah. Okay. So it's taken off. So you do pay or you don't pay? Or you are paid for them? No. It's prepaid. Okay. Okay. I understand what you mean. Yeah. So you pay through your payment for internet. That's what you mean. Yeah, but there's another more important payment form. And people don't think of it very often. And you pay for it with your data. That's your main payment. And you don't know how much you pay. You have no idea. Because they're using as you know, there's a whole market of data already. So we have data traders, and there's whole companies that exist only because they use the data from health apps of people. Because I don't know how you do that, but with every app you use, we always get a lot of questions about what they can do with it before they can start. That may be a European Union thing, because I think apps have to ask people if they agree with the use of the data. So is that the same here or not? Yeah. So we get a long list of uses, and I know almost nobody who's reading these things. So you want the app, you want it now, so you click yes and you go on. So that's the most important moment where your data are sold. And I think that's really a serious ethical issue, because we've been always very cautious about medical secrecy and having and confidentiality and things like that. And now I don't say that these are usually anonymous data, but still they're what's that? The Hello Doc, yeah. Oh, that's Hello Doc, yeah. Yes. Yeah. But I mean also that they ask you whether they can use your data, for instance, for reclama, for publicity, for that kind of stuff. So most people just click yes. Go ahead. So I'd like to just show sorry, you wanted to say something to me? No, that's not true. You can use it, but it takes time. Because you have to click on, but I usually do it. I don't give my data away like that. So I usually click on all the possibilities, and but there's usually 15 possibilities or so, and that takes too long for most people. And then at the end you can refuse. Some apps give you the option to refuse all possibilities. So all possibilities for them to use your data. Yeah, sometimes it's only accept. It's the only possibility. Yeah. No, it's true. But then I would say don't use the app. Yeah, it's a danger. And these are the most unreliable apps, are the ones who don't ask you anything or who don't give you a choice. It's a sign of reliability if they give you a choice, and the best ones give you the choice to reject everything and just use it without paying with your data. Can I have the next one, please? So this is what you can do the next one as well. Yeah. So there's in fact 3 possible business models for apps. The first one is that the client pays, like you pay for other things. Almost nobody does that because they're so-called free. So everybody, or it may be free with medical advertisement. So then they may not use your data, but you get a lot of advertisements, especially related also to the question you ask. So as soon as you ask a question about a lesion on your skin or your headache, they will send you neurology clinics with very good results. And so that's publicity. That's a way of that's a business model. And the other one is that it's free, as I said, but data is sold by data brokers, because you have international data brokers now that sell millions and millions of data to all kinds of companies. So these are the three. And I think the best one, in fact, is just to pay for an app. But it's also ethically speaking, I think apps should be paid for. And then it doesn't do anything to your privacy or confidentiality. Can I have the next one, please? So these are ethical issues from a paper by in PLOS ONE. I'm sorry for the image got a bit over the text, but anyways, it's in an article in PLOS ONE where a number of researchers did a literature study into ethical considerations around the use of apps. And then, as you see, the most important issue was privacy and confidentiality. So people are worried by far the most about privacy. And informed consent was another one where you were asked or not for the use of the data. And I think also trust is a very important issue. I'll come back to trust as an ethical principle a bit later on. It's a very important issue as well. Transparency. So this is, in fact, an overview of the most important ethical considerations related to the use of mobile apps. Maybe next one, please. I'm going to say a little bit about a project that I'm currently involved in, and that's using health apps. It started just in June 2020. It's a project funded by the Dutch Heart Association, and it intends to do, here too, the image is a bit, well, I'll just tell you. BK, it's called the BK project, and BK means beating unwitnessed cardiac arrest. So just for a bit of context, about 20% of the people per year who die from cardiac arrest, they have no one there alone. So there's no one there to help them. So for instance, they're living alone in their house, or they're taking a walk in the forest or somewhere, but there's no one there. So they're found after their heart attack and their cardiac arrest. So they usually can't be saved, or hardly can be saved. And this applies also, but more importantly, to people who are at risk for cardiac arrest, like people who have already had a heart attack or other cardiologic patients. And what these patients will receive in the project, and Philips is now developing a separate health app that can not only register, but will also call the center. We'll call a call center of first responders who will then go to the patient, because they will have the location of the patient and they will have the rhythm of the heart rhythm. So as soon as the heart rhythm drops in these patients, the watch will make a phone call to the center with the first responders, and they will come and see what's the matter. So that looks very good, doesn't it? The only problem with it, I think, is that they have to have a separate watch for it. So it can't be integrated in their own watches. Or you could also say Philips doesn't want to do that because they want to sell separate watches. It's more profitable for them. But they tell us that they can't integrate it into an existing, say, smartwatch that has Fitbit or something like that. Now, I think there's several ethical, and we're in that project to study the ethical aspects of the project. And I think there's obviously the issue of privacy, because there's a location tracker in the watch, and they need the location tracker because otherwise they're not able to come and help. So they need to know where the person is. But it means that the center may have an overview of where you are all the time. And as with the gentleman who was seeing someone, you may not want that. People may want to have their privacy. So privacy, I think, is one of the big issues. Safety is another one, but that has to do with false negatives. So they don't know what the watch will do. Will it really work very reliably, and will it show all the cases of possible cardiac arrest, or will it miss some of them? And if it misses them, then the person may still die. And then the question of accountability comes up again. So it's the question, who is responsible if the watch doesn't do its work? Is that the doctor, or is that Philips, or is that the patient? Maybe sometimes, because one of the things that will happen is that people will put it down somewhere. They will not carry it 24 hours, probably. We all put down our watch sometimes, don't we? So they will leave it. They will maybe lose it at some point, or not know where it is. And who's responsible for that kind of behavior? Because, in fact, for the watch to work, you need to wear it 24 hours, 7 days a week. But the most important point, I think, is the consequence of false positive. Because it may also say that someone is in danger while he's not in danger at all. So just try to imagine someone is lying in his bed, quietly sleeping, and the watch decides that the heart is not functioning. So it calls the people. The door is locked, so they will come. Door is locked, so they can't get in. What do? Nothing. But yeah. So they hit so they go in because they think that someone is dying there, and that they have to. And obviously they will try to get in. Yeah. So they kick in the door, or they kick in a glass or whatever. And then they find that person quietly sleeping, who's seeing burglars in his home because nothing was happening. So that's one of the, I think, ethical issues that need to be addressed. It's the extent in which false positives have negative consequences. So we'll be able to look at, and probably the watch will have a switch, because it will also make a sound, probably because of this. It will not only call the service, but it will also make a sound to the patient. So the patient will hear that the watch is calling the service. And if the patient then wakes up and realizes what's happening, then they may cancel. They may cancel the call, probably. But that's necessary for this ethical consequence. So that's in fact why we are involved as ethicists, because I must say the technical people had never thought of this possibility of damage to the houses of people and to their well-being, because it's really not nice to be woken up by burglars in the middle of the night, of course. So this is a project that maybe next time I will tell you a little bit about what came out of it and whether it worked or not. We're just at the beginning of this project. But this is the sort of mobile health apps that will probably increase in the future. So is there anything on the chat about? Do you have anything to ask about? Yes. You have a question, yes. Maybe, do you have a, where's the microphone? I can hear you, but possibly the people online can't hear you. Yeah. Okay, good.
Okay, thank you for the opportunity. Pak Dik, I have one question about the privacy, the concept of privacy that you mentioned.
Yes.
What do you see this concept of privacy that is it contactless? I mean, is it, so as we have seen in the Tegarjo primary care this morning, that privacy is something that's negotiable. So that's when we had this morning, we have talked about the end of life of one of family, and then they talk to Kader, and then Kader will talk to neighbor,
right.
Neighbor maybe talk to another neighbor,
right.
and maybe also talk to the healthcare professionals, and so many people then will know about he or her condition, and then that's kind of, privacy here is contextless, and then somehow benefit for the patients and family. So what do you think?
Well, thank you very much, because it's an important remark about privacy. We tend to use it as an absolute concept, like if privacy has always to be safeguarded, whatever happens. But if you ask, maybe that we're going to ask patients who will have this watch what they think about the privacy issue. So maybe for these patients, if they have a watch and they think that that watch may save their life, then they will be prepared probably to give up some of the privacy that so they will maybe not mind too much if other people see where they are. That's not clear. I mean, we just have to speak about that with the people who are going to wear the thing.
Yeah, so this may be, can we say that it's kind of urban bias?
Yes.
So that's, so only a certain person or certain people who can have benefit for this, but not all people can benefit for this.
Yes, that's a possibility. Yeah, but we don't know that yet. It's a possibility finally. But that would also be a bit of an ethical problem, of course, because you want it to be accessible for everybody who needs it, of course. Yeah. Yeah. Okay, thank you. It's a really concept. I think the concept is really something to remind you that privacy is a contextual concept and not a sort of absolute concept. It's more important in certain contexts and less important in others. Yeah. Okay.
There is one from online, maybe.
Oh, yeah. I think Prof. Romo was already.
Okay, thank you. You mentioned about the decline of face-to-face care, and I think it is very much what I want to say. I think it is true. Even it is not about healthcare delivery. When we are teaching with Zoom, etc., we can feel that there is a declining in personal touch and also how we can communicate each other. So, in my opinion, is that technology cannot replace human touch.
Right.
Yeah.
Right.
And in some cases, maybe it can be abuse. The abuse of technology for certain purposes. So that's why what I want to suggest that technology cannot replace human touch, because there in human touch, not only because that we have to touch, but the relation face to face with eye contact, etc. It is very much important.
Right.
In the healthcare system, in our healthcare system. Okay, thank you.
Yeah, thank you very much for supporting that. I fully agree with you. I think if you really rely only on the camera and the audio, then you will miss some things that you would see if you're face to face when you're touching someone or when you're in a face to face contact. For instance, one of the things that's difficult to see with patients is if they feel emotionally disturbed or not. So you can often, as a doctor, I've always had the idea that I felt that a patient was going to burst out crying about something because he was so afraid, so sick. But you lose that when you only have the camera. So you don't have enough. Now, some people in the ICT business say, wait just a few years and the computers will do that too. They expect that computers will be able to touch you. So yeah, we already have computers. There's surgical operations where you can have gloves that have sensors, and then the person on the other at the other end of the globe will be able to feel what you feel. So I'm not sure what will happen in the future, but for the moment, I think you're completely right. But it's something that we need to keep thinking about. So the developments are going so fast. And about 10 years ago, nobody would have believed that artificial intelligence would win from the best chess player in the world. It already does it since a long time. So, but it's true. I fully agree with you. We should keep human contact. All right. There was one from the app, yeah.
This is
From
about
the online.
telehealth from Mr. Agung Prastya. Is telehealth with video consultation application can be used to support the patient who have serious mental illness, sort of people get depression and have the experience with?
Yes. Thank you very much for the question. That's really nice that you ask it. I think.
Sorry, Professor. There is the continue that sort of people get depression and have the experience with suicidal thoughts, and also for the vulnerable people like substance use disorder.
Yes.
Is telehealth suitable for the vulnerable population that I mentioned before? Thank you, Prof.
Maybe you should make a distinction between the acute phase and the somewhat longer, maybe not chronic, but the phase in which things get better. I think if someone has suicidal thoughts, then the depression is really an acute phase. I think the experience with video consultation in the acute phase is very bad, as far as it has been done, because it's here what Prof. Romo said is really important. Here you need to be close to someone because they're desperate. But on the other hand, so that's the acute phase. On the other hand, sometimes telehealth and telecare is used for monitoring people with depression. So to have regular contact to see how they are doing. And in fact, it's one of the areas where in the Netherlands, video consultation is most developed. Because usually patients in depression, often they don't want to come. So they sometimes prefer to have a video consultation instead of coming to the office, to the health center, because they don't want to be among all those people. So they don't want to be in a waiting room for a long time. So even though the contact is less good, for them it has an advantage sometimes. So sometimes the monitoring is better through video consultation, but not the acute phase. So I think if you have people experience suicidal thoughts, then you should go and see that person or have that person come to the office and not do that through video, because then the risk of errors is much too big. It's not safe to do that. Is that the same?
Yes.
Same. Okay. Good.
The next maybe you will.
Oh, yeah. Artificial intelligence is later. Yeah. Okay.
Remaining time about 25 minutes.
Okay. I'm going a bit quickly through this one. So next, please. Next slide. I'll say a little bit about personalized medicine, because that's one of the areas where digital health is very important. So maybe next slide. So this is a definition of personalized medicine. It's the tailoring of medical treatment, and you can also say social care and other forms of care. It's not only medical, to the individual characteristics of the patient. It's the science of individualized prevention and therapy. So that's the essential thing. In medical science, we usually think in terms of patient groups, like all patients with cardiac failure or all patients with COPD. Personalized medicine tries to tailor the treatment to each individual case. So get a lot more specific. Next, please. I'm going to skip these ones because they take too much time. It's not that important. If only you know that there's a lot of meanings. So here are 10 and there are even more, but and it's often linked very much to genetics, and genetics is an important part of what a person, of the characteristics, obviously, but it's not everything. So please go to the next one, because this is really, if you look at, don't know if you can see it well, but if you look at that image to the left, that's really where you see why digital technology is so important for personalization. Because what you in fact need to do in personalized medicine is get a lot more data than you had before from a patient. And I'll show you an example a bit later. So it's really a sort of big data about one person. And as you know, with electronic health records, there's a lot of data about all of us in hospital records. And these can all be combined using big data and sometimes artificial intelligence to make personalized medicine. So please, can I have the next one? This is another image showing what it is we had before, and I think that's a nice term to keep in mind. What we had before and still have for many diseases is one size fits all medicine. So COPD treatment is the same for everybody, and only if you don't react to the treatment, then you get another treatment. But it's one size fits all normally. And then you get stratification in which you have different groups of people. So you have, let's say, elderly and children, and you have people who have other diseases, comorbidity or not. So there's all kinds of stratification. But the aim eventually is what they also call precision medicine. So it's a medical treatment that's precise for this one person. And I know that Prof. Rika, for instance, here is working a lot with personalized medicine from mainly the genetic, maybe, but she's also working on personalization in terms of preferences. As you see, the red person there, left to the red person, you see things like patient individual, the preferences, clinical features, medication history, the environment. So you have to take all of that into account to be able to have personalized medicine, behaviors and habits, biomarkers. There's a lot of things going on. So next, please. Thank you for the red. Nice. So I must say that talk about personalized medicine has started about 50 years ago. In the 1970s, people were talking about that, mainly about certain drugs, because that should be personalized. For instance, we were talking about depression, antidepressant drugs, because they have a lot of side effects and they're very slow to show the side effects. So their personalized medicine would be important. But 50 years later, it's not completely delivered as it promised 50 years later, but still we go on. And it is increasing all the time. It's now precision medicine, and I'm a bit sorry about the term precision, because I like personalization a lot more, because it is more holistic. It takes all the aspects of a person into account, not only the genetics or not only the anatomy of a person, or so it's a bit of pity that comes from the US. They like precision a lot. They're very technological, so they like precision. But I must say personal is the better term, I think. But precision medicine is used for the same things. Can I have the next one, please? It will probably be disruptive, as people say. It's a disruptive innovation. And disruptive means that it may really fundamentally change the way healthcare works. And it's including the values inherent in current healthcare systems. And for instance, the value of generalized knowledge may become smaller. And the hopes of this disruptive innovation is that patients get appropriate treatments faster, that it will cost less, have less side effects. Side effects of drugs are one of the most expensive elements of healthcare, because people have to be admitted to hospital because of side effects quite often. So it's bad for them, but it's also bad for the healthcare system. Can I have the next one, please? That's just an image of personalized medicine. It's DNA. You see the DNA at the end, at the side, but there's also a lot of other elements that make this person into the person he is. Next one, please. I will just skip this one because I have another example that I would like to discuss with you. This is a bit too long. Can I have the next one, please? They're beautiful, but that's too long. And another one. Yeah. This is one of the examples of personalized medicine and precision diagnosis that we're working on in Amsterdam UMC now, in the university center. It's the problem for many doctors in primary care is that some forms of cancer, they show very late because they have very common symptoms. So like, and one of the examples is cancer of the esophagus, so of the first part of the intestinal system. That obviously can be quite big before it gives really, let's say, alarm symptoms. It has symptoms, but they're never very clear. So what we want to do in this project is see if we can make the diagnosis of cancer more precise by combining an enormous lot of data. And these are data, and you can look at the third bullet point. It means that we need to collect daily life data. So it's data about things people do in daily life, the shops they go to, everything. In fact, in the medical files, the pharmacy files, over-the-counter drug use, and social data as well for more than 1 million persons. So it's enormous. You have an enormous database, and that's all needed to be very specific. And that's a sort of a contradiction. You have to be very specific. You need enormous amounts of data. So what will happen is that there will be data mining, as they call it. So they will get the data from all kinds of registries about these patients, and they will use machine learning. I'll get back to machine learning a bit later in the last 10 minutes or so, to find markers and to make personalized medicine possible. So it's combining enormous amounts of data of patients throughout Europe. And we're involved in that study as well to look at the ethical consequences. And one of the ethical consequences, I think, is on the next slide. The next, please. So it's not in there. One of the ethical issues, I don't know if you realize that if you gather a lot of anonymous data about one person, so very different data, like about genetics, but also about shopping behavior, about sports, about movement, then you don't need the name of that person anymore to know who it is. That's one of the things that people don't realize often. When they say, well, my data are anonymized, I'm going back to the business models. If you sell all these data from your phone to someone who will combine them, they will finally be able to track you. Even if the data were completely anonymized, no birth dates, no names, no ages, but still. So that's one of the, I think, the big ethical issues around the use of big data in healthcare, that people will become re-identifiable, as it's called. So it will be possible to identify the people. That's in fact the privacy breaches that I mentioned here as the first. So I had an example. There was one study that wanted to gather data about people, so that they had profession and they had place of residence, but not birth date and not. So they thought that was vague enough not to be able to identify these people. But then one person had to fill in that he was a mayor and that the city he was living in was Amsterdam. So there you see it. You don't need birth date and name, but you know who it is. It's just one mayor of Amsterdam. So you don't need personalized data to be able to re-identify a person. And that's something you need to realize. And that's, in fact, why I always click on all the data, that I never want anything to be sold to other people. because I will be identifiable, and it may be used against me. So another issue that I can't say a lot about because I'm not an expert in hacking and all kinds of other cybercrime, but hacking is obviously a great issue here too, because all these data may be hacked. I think about a few years ago in India, the medical files of about 35,000 people were hacked, including HIV status. So it was open for everybody who had HIV in that community. So hacking is really one of the big threats to digital health. So can I have the next one, please? So I'll get to the artificial intelligence, and that will take me about 15 minutes. Is that okay? Can I do that? Okay, good. All right. So in fact, do you all know what artificial intelligence means? It means, in fact, the basic idea is that artificial intelligence is a way of using computers in which computers themselves learn. That's the basis. So in fact, it's machine learning is the most advanced form of artificial intelligence. And you can teach them things, but that at some point they will continue to learn. That's the way how some AI systems were able to beat the world champions in chess. That was not because they were given solutions, but they invented solutions themselves. So artificial intelligence, this type of computer systems, is good at analyzing extremely large and very varied data sets, up to even unstructured text. So they used a lot of artificial intelligence in the project that I was talking about cancer in general practice. They were using handwritten files of doctors where they just wrote down text. It was not structured according to ticking boxes, but it was unstructured. And they still were able to draw conclusions from that. So and these are really enormous. There may be terabytes into these data sets about one person. So it's good at analyzing and doing that very fast, because we could also do it, but it would maybe take a year to analyze one patient. And these artificial intelligence systems are going really, really fast. And they're learning very well. So they're quick learners. They pick up things fast. And they never get tired. That's an important thing. You know that much, I don't know how much artificial intelligence use there is about here in Indonesia, but many radiologists in Holland already use artificial intelligence to assess X-ray images. Because not only they do it faster, so they have the same level of analysis all the time. While a radiologist gets tired, he gets distracted, he may have a conflict with his wife at home that makes it work. Artificial intelligence never have conflict with their wives at home. Up to now, because they maybe in the future, they may have that, but they don't have any, they don't get distracted so easily, or not at all maybe, as humans. So that's a big advantage of artificial intelligence. But there are things that artificial intelligence is not good at. One of them is taking emotions into account. So it's very difficult to information is okay, but an emotion is very difficult to deal with for an artificial intelligence system. It's really difficult. And they're not good at making ethical decisions. Now, some people, I don't have a slide about that, so maybe I can just tell you. Artificial intelligence is obviously also used in self-driving cars. And obviously sometimes self-driving cars might have to take an ethically difficult decision, because they may have to maybe choose when they can't avoid a passenger or two pedestrians crossing the street, the car may need to choose between, let's say, the very old lady and the young child. So how do you teach a self-driving car, an AI system, to make that choice? But they're doing it already. So they give them ethical dilemmas, and they try to let them they try to teach them to take ethical decisions. It's the same for, I don't know if I've been think about the trolley problem before. Did I speak about? Yeah, I mentioned it somewhere. I don't know why, when. I don't know why to, but when. Do you know what do you know what the trolley problem is? It's an ethical. You know it, Tui, of course. Yeah. Could you say what it is? You get a microphone. Get a microphone.
Oh, it's on. So, the trolley to go which direction, he has then to choose towards which direction this goes. Something, and at the other way also.
Yeah. That's it. Yes. Well, the trolley problem says it's a bit of an artificial problem where you have a rail track and it splits. So you have a switch where you can decide where it goes. And then on one of the rail tracks, there are 5 people who are attached to the rail track. They can't get loose. And on the other one, there's just one. And then there's a train that can't be stopped, but that has to be sent to one of the directions. So then the trolley problem is the question, where do you have the switch? Where do you go? Where do you send it? Does it go to the one person or to the 5 persons? Now, some people don't want to answer that question, which I think is the most reasonable answer. I'm not going to answer bizarre questions, but it tells us something about the way people reason. So most people will then, if they answer, they will say that they will send it to the first, to the one person. And this you can teach also the trolley problem to, for instance, an artificial intelligence system in a car, or to a doctor maybe, or maybe to a medical artificial intelligence system too. So can I have the next one? Because I have an example. I don't know if it's already here. Yeah. This is the example I want to show to you. It's very recent, and it's from my hospital, and I think it's a premiere in the world almost. I don't know if you heard about it in Holland. No, what they want to do, and they already do in the ICU in my hospital, is that they use artificial intelligence to determine discharge from the ICU. So to determine whether a patient can be sent back to the regular ward in the hospital. And the problem is that much too often, to the view of most people, patients need to be readmitted after having been discharged. So they are discharged, and then it goes worse with them, and they have to come back to the ICU. And the problem with that is that it leads to higher mortality. So it's better for patients to keep them on the ICU if they still need it, and it's better to only send them back only discharge them if you're sure that they're able to survive outside of the ICU. Now in September, so this month, Amsterdam UMC was premiered. It was in quite a few newspapers because they want to do this discharge decision on the advice of artificial intelligence. So the artificial intelligence will in fact get the whole patient file with everything in it, and then it will calculate. So that's an enormous amount of digital information, because the ICU generates really infinite amounts of information. So based on that digital information about the patient, the AI system will advise to discharge or keep the patient on the ICU. So, and they hope that will be better for the patient because of the lower mortality, because the mortality related to too early discharge. So what do you think there's any ethical issues there? So it's really the computer who starts to decide, or at least advise doctors to discharge someone from the ICU. What do you see as an ethical issue there? Yeah, TV. Yeah, microphone. Ha. Oh, that one works. Don't fall over the. No.
I think, Prof. Dick, it should be undergone the research first, comparing AI only, yeah,
yes,
and AI and person only. So before it is applied, it should be undergone research.
Right.
So
yes.
So
yes.
if there is, even though it still have a false positive or false negative, but it's minimum.
Yes.
So that the
Yes.
the comparison of that, it should be
Yes. Yeah.
Problems with it.
Yeah.
Yeah.
Yeah. Sure.
Yeah.
Yes. Thank you. Thank you very much. You're quite right. It should be. There should be scientific evidence, especially in something so dangerous as discharge from ICU, because these are people who may die any moment. They're in life-threatening situation. So there should be proof that it is safe to do this. What they've tried in a sort of a pilot, they tried it. And what they then did was that they took the decision as a human, as they always did, and then they had they ran the AI after that. And then they just looked which decisions were different and which were the same. And then finally, the doctors in the pilot decided what happened. So they decided whether the patient was discharged or not. So that it has had some testing, not enough probably. So they will go on testing it, but they will now start using it, but keep testing against doctors' judgments. In the pilot, it was clear that the AI made better judgments than the doctors. So it had better prognosis than the doctors. And that's difficult for doctors to realize that a machine does better than they did. But that's because the AI can process so much more information at the same time. That's really the reason. And so that's one thing. It should be investigated. I think there's another ethical issue. I don't know if you're ever involved in decisions about discharge, but there's often a lot of emotion, and a lot of family pressure on. So we get consulted by the ICU quite often about question about discharging, and then the doctors usually think that it's possible to discharge, but the families don't agree, and the patient sometimes also doesn't agree. So what the AI cannot do, I think, is take those things into account. So whether a patient feels safe going back from the ICU to the ward, or whether the family may feel very unsafe. So those, let's say, more soft things are difficult for artificial intelligence because they can only work with numbers and data. But it's difficult to put this into data. But on the other hand, the people that are working on AI say that shouldn't be, they will do that one day because it's evolving very quickly. So they will get AI to also take into account emotions. So this is maybe in the future, this may be less serious, but I think you're right that safety should be investigated first of all. And the question, of course, also is whether you should inform the patient, because that's one of the other difficult issues. If you say to a patient that, in fact, the computer will have an important influence about the decision, then they may not trust that. Because most patients will trust the doctor more than the computer, I think, even though that may be changing. But so there's an issue of informed consent. And that's also because a doctor usually can explain his decisions, but an AI system is a black box. That's important. This is a term that you should maybe not forget after this lecture, that AI systems, especially self-learning systems, are black boxes. So the doctors who use it do not know how it works. Just like the world champion in chess who was beaten by the chess computer didn't know how that computer came to its. So he had no clue how to do that. So they're black boxes. So it's very difficult to explain to them, to the doctors, but also to the patients, how and why a certain advice is given or a decision is taken. So I think that's another ethical issue, the informed consent issue here. Yeah. So that's yes, Tui. Now you lost the microphone.
I'm curious if you know also how others respond on this, because as I know, I mean, traditionally there will be a doctor in charge or who is responsible. Then when, for example, this AI says discharge, for example, and then although the doctor they still do it, and then how about the responsibility or who?
Yeah, very good. This is a central issue. That's really central because many doctors, in fact, all doctors who work with artificial intelligence say, I remain in charge. Whatever the AI says, it's the doctor who decides finally. We're in another project that I wasn't able to show to you, where we use AI to decide which patient will get an implantable cardio defibrillator after having had a heart attack. So, and there again, the cardiologist said, it's all nice, artificial intelligence, but I'm the one who keeps the decision. So I'm in charge. I agree with them a lot, but I'm not sure if it's going to work. Because if the AI all the time shows that they have better judgments than doctors, then I think many people will think, why believe the doctors if they can't do it? So I think it will be a hard time for doctors to keep proving that they have to remain in charge. And one of the reasons why they should remain in charge, I think, is because they can integrate other things like emotions and like family context, like social context of patients. And that's a lot harder for artificial intelligence to do. But it will be, I mean, I think it's a very exciting period because we just don't know what it will do at the end, the artificial intelligence. And, you know, if you look at an insurance company, they will say, we want the best. So they will say, listen to the AI, probably. So there will be quite some pressure on the doctors to, but I do agree with you, Tui. I think now, as it stands now, it's the doctors who remain responsible. And they should keep that responsibility too. But they should be maybe also try to understand as much as possible what the artificial intelligence does to be able to keep that responsibility. Otherwise, they will maybe in the end lose it. Yeah. Yeah. You don't have a microphone. That's
about your involvement in this research, Peter. It is what is the role of the ethicist in there?
Yeah.
What do you do? I mean, in that in that research, yeah.
Yeah.
Because if there is a case in false positive or false negative, and then also when the doctor actually said that, but then if the artificial intelligence show many, I mean, the better judgment, yeah. So what is the role of ethicists here?
Yeah, well,
And yeah, especially you.
yes. Well, what we do is we do a study. So we interview both patients and doctors about their views on the use of artificial intelligence and how they want it. And if they think, so where they think the responsibility should be. So that's one thing, but we also try to talk, we talk to people who develop the programs to tell them. So in fact, what we need to have probably is an artificial intelligence that sticks to its own limits and that doesn't go farther. And that's the kind of thing we, as ethicists, we also talk to the technicians and to other people. We also say to them, how can you guarantee that it will not transgress its own borders? And those things. So we do studies. We interview, in fact, everybody involved about the ethical issues related to the use of artificial intelligence, which is a lot, like privacy, responsibility, explainability is another issue. So how transparent do they make the AI? So all those issues we discuss about with the developers and with the users. So that's what we do. Yeah, yeah. Is there anything in the chat as far as you know? 7, and there was an earlier chat already about the artificial intelligence issue, I think. Oh yes, oh yes.
This is from Mr. M. Agung Prasetya. I'm sorry, Professor. I want to ask a question about artificial intelligence. As you mentioned in your previous slide, artificial intelligence can improve health outcome and its applicable solution for clinical practice. Can you give one example about the artificial intelligence in hospital setting? Is CT scan included artificial intelligence? Thank you so much.
Okay, thank you. Thank you very much for the question already a lot earlier. So I've been speaking about 2 examples which I'm involved in where artificial intelligence is used. So the one is the decision about whether someone gets an implanted cardio defibrillator. So that then that cardio defibrillator that gives a shock to the heart when it stops. So it's like the AEDs. You have them here too. The artificial external defibrillators. You have them in shopping malls so some people get them implanted. And the AI, what the AI does is also figuring out for whom this would be necessary and for whom it would not be necessary, because the criteria that doctors now use are not sufficient, because there are people who get the ICD who never use it, so they should probably not have had it. And there are also people who die from cardiac arrest and who don't have the ICD, so they should be they were safe. So there are false positives and false negatives, and too many. So that's one example. Well, the other one was the one about discharge from the ICU, where artificial intelligence is used. CT scans, to my knowledge, don't always include artificial intelligence, but sometimes. And I know that radiologists use artificial intelligence quite a lot to look at the more complicated images. So it's used there quite a lot. Yes. Questions keep coming in. I think
one more. Yeah, one more from Prof. Sophia.
Prof. Sophia, nice,
Mubarika.
nice. Yeah.
Personalized medicine is not fully accessible by the unfortunate poor because the price of the analysis are expensive. Also, the target therapy is not cheap. They are not covered by the insurance. How about in the Netherlands experience?
Yeah, it's really true that personalized medicine is at the moment is more expensive than regular medicine. So that makes it also hard to develop it further, because the analysis as we have them now are quite expensive. But as we all know, these things tend to get cheaper very, very quickly. So I think the price of the analysis may go down. The other issue, and that you mentioned that, fortunately also, Prof. Sophia, is that the target therapies will probably become more expensive. And that's an issue. So some drugs will be only use of, or the drugs will be used by very small groups only. And that puts a high demand on the production of drugs and the expenses for new drugs. So I think that's, to be honest, we are thinking about this, and obviously the Netherlands is a richer country per head of the population. So usually this will still be covered by insurance, but there will be a limit to that. And it's a limit that we don't have a solution for at the moment, except that the analysis will get cheaper and that we will need to have cheaper forms of development of drugs in personalized medicine. Don't know if that helps you, but these are the lines that we're trying to develop it in. Thank you for the question, Prof. Sophia.
I'm sorry, Professor. I think we just ran out of time. Is it 3:15
It's
now?
3:15, yeah. I have to until 3:30 if necessary.
Okay.
I said I would be a bit late. Well, we can also stop here, then I can go to the other one. Yeah.
Okay.
It's been long for you too. I can answer. You know, what we can do is answer the question through...
One question from
Yeah.
Mr. Arif, maybe? The last question.
Yeah.
This is the question for Mr. Arif. My question is how artificial intelligence works.
Yeah, I can read
Yeah.
it. So it's about how is AI securing patients' data? Well, for the moment, I think I don't know of any leaking of data through AI. It's sometimes through other ways, but it's one of the ethical demands that we will raise to every new artificial intelligence project. And the faster response in prolonging patients' life. I think there are possibilities. There's a lot of possibilities of AI to find new and faster ways of treating a patient and prolonging the patient's life. I think that's one of the really good things about artificial intelligence, that it combines so much faster than we can, that you can also be faster in the response. Yeah, maybe the
How about it? Also, maybe you want to...
This will be more a comment than, and this is more about the telecare part that I was talking about. So the Internet of Things, where both the doors and the toilet bowl and the electric kettle give messages to call centers. And I think it's true. It's really an issue. It's also really an issue of privacy that the Internet of Things raises specific issues also with false positive and negatives. They're taken as a technical issue, but they are not a technical issue alone, because it's also about the value that you attach to them. That's not a technical issue. So thank you very much for that question too. So shall we end here then?
Yes, I think.
Okay. So thank you very much for your attention.
Okay, big applause.
Thank you. It was a long post-lunch meeting, I think. For some of us, it's a bit difficult to keep awake. Well, I would have had the same, but if you have to speak, you don't fall asleep. So, well. But thank you also for the online audience. You've been with us for almost a full 2 hours, so that's really nice. Thank you, and for your questions.
Thank you very much. Thank you, Professor Dick Willems, for your great presentation. Distinguished guests, ladies and gentlemen, before it is ended, I have take-home message from this presentation. Digital health, for example, telemedicine, telecare, mobile health, personalized medicine, artificial intelligence should be an integral part of health priorities and benefit people in a way that is ethical, safe, secure, reliable, equitable, and sustainable. So this is finally of the lecture of visiting professor. And I hope this presentation will give us wider perspective about digital technology application in healthcare delivery. So thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. Thank you very much. Applause.
Small appreciation for you. It's the something from the study program.
Okay.
Yeah, and also the certificate.
This is from